With this, we would start with our consensus statement meeting. We would have series of lectures. Each lecture would be followed by a voting. The voting would be on specific questions which are pre-designed by Simon and me, and each question will be played for 15 seconds, and you'll have to click the answers in 1 to whatever the options you want to select. The options are labeled as A, B, C, D, E, F. Now, I hope everyone has received the voting pads and they have signed the consent. If anyone has not received, kindly raise your hand. Yeah. So, coordinators, can you ensure that they get voting pads and the answer sheets and the consent forms? Now, before we start, let me explain you how to use this voting pad. Is it seen? Can it be seen? Yeah, so there's a red button which says CE. You have to put on the button. Once it is on, then the pad is on. You select whichever option you feel appropriate, and then the green button there which says OK, just press the OK, your response is recorded. So first red button which is on, then select one of the option and then put OK. Once you do that's how your vote would be recorded. Now there's one more announcement before we start the proceedings. In Hall B we have a session for residents which is going on, but because of paucity of residents, we have requested all the faculty there to join in Hall A as a part of this meeting, and whenever the residents would come, that meeting can be restarted. But we would have a quiz for residents between 2 to 3 p.m. Hopefully by the time we would have all the residents coming up. So with this I would request Dr. Utsav Shah to come on the stage. He would introduce the first set of lectures. Thank you.
Good morning, everyone. I would like to welcome the chairpersons for this session, Dr. Narmada Gupta sir, Dr. Arnold Stenzel, and Dr. Kalyan Sarkar. The first lecture will be by Dr. Raj Nair on Introduction to the Small Renal Mass Consensus Statement and Voting.
So welcome. It's very nice to see such a good and large audience here today. I'm very grateful for the invitation for coming, and thank you all in particular for helping participate in this consensus statement. Essentially, as discussed before, what we're trying to do is determine areas in where consensus guidelines would be beneficial, but also see what your views are upon very topical issues through the program. All this voting is anonymous, so don't worry, it's not an exam. You're not one of the residents here, you've already finished your exams, I hope. So this is really just to see how you would practice in particular clinical scenarios that we're going to give you. In order for a consensus to happen, we are looking to get 75% agreement and about 25% of obviously disagreement. So the most important thing you can do is find those pads and vote, because if we can get as many people voting, then we can get a representation of what people's feelings are. So without further ado, I'm just going to introduce the first topic, which is the small renal mass. And we've already seen from our talks this morning, both on SABRE and the RCC tumor board, there's so much contention with just one small renal mass. And for your voting, the definition of a small renal mass is a tumor which is cystic or solid, which enhances on CT scan less than or equal to 4 centimeters in size. And the patient we are describing is someone with a performance status of less than 2, and has at least a survival of 6 months or more. So keep that in mind when you're voting and when you're doing your clicking on your buzzer. And I'll be joining the panel and look forward to all the talks this morning.
With this, I would like to invite Dr. Gopal Sharma to talk on optimal diagnostic imaging on SRM.
Thank you very much, Dr. Utsav, and good morning everyone and respected chairmen. And I'll be touching upon a topic which is basically in the domain of radiodiagnosis, and I'll be giving the urologist point of view when we are dealing with what is the optimal diagnostic imaging when we are dealing with management of small renal masses. So what are the aims of imaging when we get a patient with a small renal mass? First, obviously it is whether it is a benign or a malignant lesion, and if possible can we get the histological type, and the last two are mainly related to staging and preoperative planning, whether we are going to do partial or a radical nephrectomy. The first investigation, more or less the patient which comes with, is the ultrasound, and ultrasound is itself a very good investigation, and it can diagnose about 80% of patients with renal masses conclusively as simple renal cysts. So what are the characteristics of simple renal cysts? They can be, simple renal cysts have very specific characteristics. If the mass is anechoic with sharply defined back wall with one or two septations, then it is called a simple renal cyst. Now it can have some atypical features which can be seen in one of the first image here is the presence of calcification. Then if there are any solid component and there are any multiple septas, or if there is any nodular lesion within the cyst, these are atypical features and they require further imaging. So more or less for we as a surgeon, we are more familiar with CT scan, and such patients invariably undergo multiphasic CT scan. I'll be discussing in the further slides what actually multiphasic is. So what are the advantages of CT scan? First, it is easily available, it is more familiar to the surgeons, it has good diagnostic accuracy for the renal masses, and it takes less time for the diagnosis for conducting the study per se. So what are we again looking for in the CT scan? We are looking for the function and morphology of the other kidney, the primary tumor extension, whether the tumor involves the venous system or whether there are lymph nodes enlarged, and what is the status of adrenal and the adjacent solid organs. So there are certain optimal criteria which are required to be met when a patient undergoes CT scan for a renal mass evaluation. First of all, the sections should be very thin, about 2 to 3 mm in thickness, and multiphasic scan is required, the first of which is a non-contrast imaging. The next phases are corticomedullary, which is taken at about 40 to 70 seconds. The third is nephrogenic phase, and the last is excretory phase. So for diagnosis of a small renal mass, 3 phases of these are actually mandatory and other 2 are optional. So non-contrast, nephrogenic and excretory are mandatory, and corticomedullary is somewhat optional. So what do we look for in non-contrast imaging? The first thing is we look at the HU of the mass, Hounsfield union of the mass, and then look for presence of macroscopic fat, and third obviously calcification. So there are two findings which can conclusively diagnose a patient having a benign cyst even on NCCT scan. So if a patient has a hyperdense mass with more than 70 HU or homogeneously low attenuation mass with -10 to +220 HU, then it is a conclusively benign cyst. And a patient who has a homogeneous exophytic mass with angular interface and with presence of macroscopic fat, it can be conclusively diagnosed as angiomyolipoma. Now the dilemma in this situation could be crept up due to fat poor AML and fat containing RCCs, which may not be conclusively diagnosed, and mind you, these two entities are even difficult to differentiate on further even on contrast NAN-CT scans. So there are some pointers to differentiate fat poor AMLs to RCC. Now in terms of enhancement, both of these tumors are well enhancing. However, calcification is only seen in RCC and higher baseline attenuation is seen with AML, and these are certain pointers, and even with these even with a well-conducted CT scan, it is very difficult to differentiate a fat poor AML with RCC. And now the next phases are corticomedullary and nephrogenic phase. In corticomedullary phase, which is taken a bit earlier in about 40 to 60 seconds, there is well enhancement of the cortical region of the kidney. And in nephrogenic phase, there is homogeneous enhancement of the complete kidney. So if there is any centrally located mass in the corticomedullary phase, because centrally located mass appears hypoattenuated, it may be missed. Like in this case, this centrally located hypoattenuated mass is not clearly seen on corticomedullary, but it is clearly seen as a hypoattenuating mass on nephrogenic phase. So once these patients are subject to contrast enhancement, an enhancement of 20 HU, and EAU guidelines take it as about 15 HU. If it is so roughly it is 15 to 20 HU. If it is more than 15 to 20 in HU, it is described as enhancing, and 10 to 20 is indeterminate, and less than 10 HU is non-enhancing. So this is basically a flow chart how to deal with such masses when we have a renal mass. Once a renal mass, if it has conclusively presence of macroscopic fat, then we are sure about the diagnosis of angiomyolipoma. The problem arises when it doesn't have which is the most common situation, when it doesn't have this macroscopic fat, and then we are looking for other diagnosis, and this patient would be subjected to contrast CT scan, and if it may or it may not show enhancement. So most commonly oncocytoma and clear cell RCCs are well enhancing tumors, and papillary and chromophobe RCCs are poorly enhancing tumors. So again, it is very difficult to differentiate between clear cell RCCs and oncocytoma on the basis of imagings, because they have very similar enhancement patterns, and they show similar signs, that is central scar sign. Central scar sign was considered characteristic of oncocytoma, but it is also seen in some clear cell RCCs due to central necrosis. And enhancement inversion, this means that in the initial phases such as nephrogenic phases, the outer cortical part is more enhancing as compared to medullary part. There is inversion of enhancement in the later phases such as excretory phase, that the inner part is more enhancing and the outer part, which is cortex, is less enhancing. It is seen with both clear cell RCCs and oncocytoma. So on the basis of imaging, particularly CT or MRI, it is very difficult to differentiate clear cell RCC from oncocytomas. And a newer investigation which has come up, and it has shown a very good sensitivity and specificity and diagnostic accuracy, is the CEUS, and it makes use of microbubble contrast agents such as PFCs or sulfur hexafluoride, and it produces microbubbles that rapidly oscillate in the presence of sound waves, and it has the advantage that it can be performed very well in renal failure. But however, it is not easily available everywhere, and it is like it has one of the limitations of ultrasound being user dependent. So it has its own advantages in differentiating solid to cystic lesions, and it can differentiate solid renal mass from solid renal tumors, which are basically columns of Bertini, and it can differentiate very well between type 2F and type 3 cysts, and it can characterize certain indeterminate renal masses on CT scans. So the next investigation is MRI. The possible advantages of MRI are that it can be done in patients who have allergies to the contrast, iodinated contrast, and it can be done in pregnancy, and it provides no radiation exposure. It has superior enhancement characteristics, and it is considered superior to CT for differentiation of type 2F and type 3 cysts. Now, just like prostate cancer, there are algorithms for differentiating renal masses, and there are certain protocols been described for multiparametric MRI, in which the T1, T2 phases are done for anatomical information, and chemical shift imaging is done to display microscopic and macroscopic fat, and diffusion weightage imagings are done to assess the tumor cell density, and contrast enhancement is done to display tumor vascularity. So if a mass shows a low signal intensity on T2 weighted images. It could be either fat poor AML or papillary RCC due to presence of fat in them. And if it has high to intermediate signal intensity, it could be oncocytoma or clear cell RCC. Now, if it shows rapid and intense enhancement, then the differentials could be clear cell and fat poor AML, and gradual and less enhancement is seen with papillary RCC and chromophobe RCC. So, the second thing is regarding the chemical shift imaging, which is basically due to presence of fat. So, AMLs have scattered fat and clear cell RCCs have intracellular lipids, so they show signal drop in out phase as compared to in phase, and hypointense out phase signal is seen in which is a characteristic of papillary RCC. So this can differentiate fat poor AML to papillary RCC, but all of these are very difficult to some of the tumors are very difficult to differentiate and characterize from each other. So the possible advantage of diffusion weighted imaging is that the ADC values have been found to be inversely correlated to the grade of tumor. So higher the ADC value, the lower the grade of the tumor. So this table very well describes the characteristics of various tumors which could be seen on different phases of MRI, which is that is basically multiparametric MRI, and there are various scores or models developed to differentiate these to predict the likelihood probability of clear cell carcinoma, I think, which is beyond our scope to read and learn, I think, which is in the purview of the radiologist to know. And there are some other novel methods coming up, such as SPECT, Sesame scan, and in Sesame scan the uptake is higher in oncocytomas as compared to clear cell RCCs, as it can be seen from this image that this renal mass on imaging and on isotope uptake, it shows higher higher isotope uptake in this renal mass, which was found to be oncocytoma, as compared to this renal mass which didn't show any isotope uptake and was later found to be clear cell RCC. So there are some other investigations some of which have been approved and some of which are still in research pipeline, such as girentuximab PET CT and FDG PET CT, even PSMA PET CT and acetate PET CT. They are coming up in big time, but they are still not common in clinical use. And the future for this is the radiomics and AI, in which the image would be acquired, and from area of interest, various characteristics of the tumor such as shape, intensity and texture would be taken, and they would be fed into a machine learning model to give different outcomes to us, such as tumor subtype, nuclear grade, radiogenomics. This is really a thing in the future and looks interesting. So finally, for staging workup and for these small renal masses which are less than 4 centimeter, the guidelines are more or less clear about it, that for staging workup, CT chest is not necessarily needed for patients with clinically T1A masses due to low risk of lung metastasis, and CT chest can be considered in patients who are symptomatic and who have abnormal chest X-rays. Thank you very much. Voting.
Simon, you started.
Excellent, thank you. Can I just check everyone's got a voting thing? You'll put your hands up if you've got a little voting pad. Excellent, thank you.
Somebody who has not got it can get it. I can see a few hands which are not raised. Yeah, Dr. Chandramohan.
Yeah.
Please be fast.
Now let us get the voting
Thank you.
pads to 100%. Yeah? Where is the team with voting pads? Put up your hands, please. Where are you? No, the team. Let's do it fast. We've got only 4 or 5 people who have not got voting pads.
And we'd also like everyone to fill in the consent form as
Pause
well.
for a few minutes until they get the voting pad.
And the consent form's important for us as well. It's also got a bit of demographic data on there as well for us. Whilst we're collecting it, I just wanted to...
Alan hasn't got, yeah.
Yeah. I'll just take you through the voting as well. If we can just put one of the voting things up on the screen, just so I can explain.
Just look at me, just repeating what Ravi said. This voting pad has got a red button which says CE. Press that button to put it on. Now, if options are, ignore the ABC. It's the 1, 2, 3, 4, 5, 6.
No.
A, B, C, D, E, F. A, B, C, D, E, F. That contains the A, B, C, D, E, F. That's right. So we get options like that. If you think D is the option, you press D and press OK. Then only it will go through. I repeat once again. Press the red button on the right hand side of the vote pad. Press your option, A, B, C, D, E, F, whichever, and press OK. So 3 steps. Red button, option, OK.
The other
Anybody
thing
any
I
question?
wanted to say is that we're trying to get a 75% consensus. So if there's a particular question that's not your specialist field, can you vote F rather than neutral? Because if you vote neutral, it's counted in the 75%, whereas if you vote F, it isn't. Okay?
Now, are we 100%? Has anybody else left out without not getting a vote pad? We are there. Any questions about voting on the vote pads? No. Salman, it's all yours.
Okay, so just remember F if it's not your specialist field. Otherwise, it's like a to E. And there's a couple of times where we've changed it slightly. So you're also going to see a timer for about 15 seconds after each question. So you've got to get voting quickly. Okay? So to start with, this is our first of our 5 statements for diagnostic imaging. Patients with small renal mass should have systemic imaging to complete their clinical staging. Can you vote now?
They should not?
No, because otherwise people just want to copy that. Okay, can we move to the next question? So next question, the optimal systemic imaging modality for patients with a small renal mass is a CT chest, abdomen, pelvis. Can you vote now, please?
Please keep on noticing that the real-time vote results are there. And we're going to collate this data for publication. Okay?
So all those whites have not voted, or all the greens have not voted.
Okay. So statement 3, the optimal systemic imaging modality for patients with a small renal mass is an FDG PET. Can you vote now? That's important as well. Okay, statement 4. Patients with a small renal mass should be offered a sestamibi SPECT CT to to aid local diagnosis and avoid unnecessary surgical excision or percutaneous biopsy. Or they may not be handed out.
If you notice your vote pad number, it comes up there whether your vote has gone through or not.
It's like the bingo, isn't it? So the last statement in this section, patients with a suspected oncocytoma should be offered a sestamibi SPECT CT to aid local diagnosis and avoid surgical excision or percutaneous biopsy. I think we're going to go back and forward to the Okay, thank you. So we'll move on to the...
Thank you. First round of voting. Yeah.
So we move ahead, and I would like to invite Dr. Rusbanu Nayak for his talk on the role of renal mass biopsy, including accuracy and complications.
Good morning, everyone. At the beginning, I'd like to thank Dr. Amit Ghosh, Dr. Ravi, and Tarun for the invitation. And it's a pleasure to be in Calcutta. Especially, I could actually thank Rajesh Nair. I could personally met him, and Dr. Prakar. I've met them a long time back when I was in Gayatri. So it was a pleasure to meet them again here. Today, I'll be speaking on role of renal mass biopsy, including accuracy and complications. So I'll be covering my topic on the following headings: introductions, indications of renal mass biopsies, and the comparison between FNAC and core needle biopsy, the complications, its accuracy in diagnosis, the non-diagnostic rate, its clinical implications, and finally the important take-home. All of us sitting here know the standard teachings for the indications of renal mass biopsy used to be metastatic RCC, lymphoma, renal abscess, and secondaries to the kidneys. But today we'll be talking more on the small indications and its complications and accuracy of biopsy in the small renal mass. Historically, renal mass biopsy had a limited role in the routine clinical practice because of the inertia and the technical limitations. Recently, there is an emergence of the renal mass biopsy. It has been used as a useful tool to aid in appropriate clinical diagnosis and individualized clinical decision making. The decision making in renal mass usually based upon the imaging, either it is a CT based or MRI based, or maybe in a cystic renal mass it could be contrast enhanced ultrasound mass. The CT and MRI imagings have all been properly discussed by my previous speaker, so I am not going into details into CT and imaging based diagnosis. So since the decision making in renal mass biopsy is usually on imaging, then where does the role of renal mass biopsy comes in deciding the treatment in renal mass? To enumerate the indications, to repeat again, the most common indication used to be the lymphoma when there is a suspicion of renal abscess, or when there is secondaries to the kidneys, or in patient with metastatic RCC. But recently there is an emergence to find the role of renal mass biopsy in indeterminate small renal masses and abdominal imaging, and patients with incidentaloma who are the candidates for active surveillance or ablative therapy, and patients those who have undergone thermal ablation to confirm the histological success and to monitor for the recurrence. The relative indications are patients with multifocal bilateral tumors, patients with solitary kidney, those who are medically unfit, and also in young patients to find out the exact histological subtype to decide the further treatment. So today I'll be focusing mostly on the small renal masses, the indications of renal mass biopsy, the complications and the accuracy in diagnosing. The biopsy is usually done on the basis of by either by the ultrasound or CT guidance. What sort of guidance? That usually depends upon the provider's experience and the level of comfort. Between the CT and ultrasound, there is no major benefit of one option over the other. However, the ultrasound is relatively cheaper and quicker, and it has lack of ionizing radiation, where the CT precise, though there is more precise localization, CT actually gives you little radiation. So these are the different images of how ultrasound and CT guided biopsy is being performed. Now coming to the type of the needle that is routinely being used. Typically, it's a coaxial sheath, and the needle size is typically 18 to 20 gauge, and in most of the cases, at least 2 to 3 cores are usually taken during the renal mass biopsy. So when to talk about the FNAC, typically the size of the needle in FNAC is 22 to 25 gauge, and it is beneficial particularly in cystic lesion. However, it has a lower sensitivity to diagnosis of malignant renal mass when you compare to that core needle biopsy. So Yang et al. Has actually proposed a combination of FNAC with core needle biopsy, which improved its diagnostic ability to 92% in comparison to only FNAC, which has a diagnostic rate of 72%. So when you compare FNAC with percutaneous core biopsy, the non-diagnostic rate of FNAC is 11%, whereas it is only 3% in core needle biopsy. And to accurately diagnose the histological subtypes, FNAC has an 86% accuracy rate, whereas percutaneous biopsy has a 90% accuracy rate to diagnose the histological subtypes. Similarly, to exactly grade the disease, FNAC has only 28% accuracy to tell about the Forman grading, whereas the core needle percutaneous biopsy has a 76% accuracy to diagnose the Forman's grading. The EU guideline panel has recommended whenever a biopsy is recommended, it has to be a percutaneous core biopsy, not an FNAC. So those who actually, the proponents of renal mass biopsy, they have actually tried to sub-classify the biopsy findings into 4 different categories. The findings, either it could be benign, if it is angiomyolipoma, oncocytoma or fibroma, or it could be favorable malignancy when the biopsy finding is either a chromophobe or papillary Forman type 1, papillary type 1 and Forman grade 1, or it could be an intermediate malignancy when there is Forman grade 1 to clear cell RCC or papillary type 1 grade 2 RCC. It is an unfavorable malignancy if there is clear cell Forman grade 3 and grade 4, or it is type 2 papillary or a sarcomatid variants. So on this basis, they have also proposed the treatment modalities. If it is a favorable malignant variant, they have proposed active surveillance. If the malignancy is unfavorable, they have recommended treatment, active treatment. In intermediate malignancy, again, if the size is less than 2 centimeter, one can opt for active surveillance. If it is 2 to 4, then one can opt for active treatment. Since this is an invasive procedure, now renal mass biopsy is definitely not without having any complications. The most common complication is actually perirenal hematoma, which occurs around 5% of the cases. Other common complications like venous bleeding, sometimes hematuria and significant pain. The most, but another important complications that most urologists are worried about is the potential risk of tumor seedling, which is actually, as per the literature, is actually the percentage of the tumor seeding after percutaneous core biopsy is very, very rare. It's around 0.01%. So this is a paper from UK. It's a tertiary care referral center. There are only case reports that are available for tumor seedling after the tumor percutaneous biopsy. These are the 7 cases that has been reported from the UK. And however, there is pathological upstaging can happen if you do a percutaneous needle biopsy because of the perinephric fat involvement. It happens around 1.2% of the patients. In a multivariate logistic model analysis, the renal mass biopsy was associated with PT3A perinephric upstaging. Its effect is small, so ultimately it has an unclear clinical significance. This is again another paper which few case reports, 6 case reports from another center. Almost all these cases were papillary RCC, they're settling into the perinephric tissue. When all these patients were followed up for longer time, there is no recurrence or metastasis was observed in papillary RCC when you compare that patients without tumor settling after the biopsy. So now coming to the accuracy, the overall diagnostic accuracy of renal mass biopsy is around 90%, it's range between 80 to 96%. However, it has a non-diagnostic rate up to 0 to 23%. And if you talk about the tumor histology, when you do a definitive treatment, either partial or radical nephrectomy, the concordance rate was found to be 90%. When you talk about the concordance in tumor grading, if you grade them into either low grade or high grade in two-tier system, the renal mass biopsy has accuracy of 87% in grade concordance, but when you grade them in grade 1, 2, 3, 4, the concordance rate drops further down to 60%. So this is again another systematic review and meta-analysis. The non-diagnostic rate in this systematic review and meta-analysis was 14%. And there are 12 studies in this meta-analysis, in this systematic review, which actually have reported on the grading. The grades were assigned in 67% of the cases. 87% of those grades are low grade and 12% are high grade. The concordance rate varies between 50 to 75%. However, 16% of these patients were ultimately graded to high grade on the final pathologies. So the concordance rate in grading varies between 50 to 75%. Because of the inter-observer variability, and also there is within the tumor itself, there is grade heterogeneity, and this grade heterogeneity can actually questions the reliability of renal mass biopsy to decide to put the patient on active surveillance. The patient and tumor characteristic which can predict the non-diagnostic renal mass biopsy. This is another series of 565 patients. The non-diagnostic rate in this series was 14% when all the tumors were taken into account, all the tumors less than 7 centimeter, but when only less than 4 centimeters tumors were taken into account, the non-diagnostic rate was around 17.4%. The independent predictors for non-diagnostic biopsy are the cystic nature, and if the enhancement is less than 20 Hounsfield unit on the CT, if there is less tumor diameter and more skin to tumor distance. The non-diagnostic biopsy on a NOT cell, the non-diagnostic biopsy is between 10 to 20%, and the reasons are because either the lesion might have been missed during the biopsy and picking up only normal renal parenchyma or the perinephric fat, and sometimes the pathologists are unable to differentiate between benign and malignant tissue either because of the necrosis or there is inadequate tissue sampling. So in a NOT cell, tumor, when the tumor size is less and the location of tumor is anterior, upper polar or perihilar or endophytic tumor, and there is more skin to tumor distance, and if the tumor is cystic, the chances of non-diagnostic rate significantly goes up. Then how to improve the diagnostic rate? Though the proponents of renal mass biopsy, they have actually proposed multi-quadrant biopsy like your prostate biopsy. If you do a multi-quadrant biopsy, the non-diagnostic rate decreases from 11% to 0%. And also there is molecular, they have proposed for the molecular characterization of tissue using either fluorescent in situ hybridization or gene microarray. Using these two techniques, the non-diagnostic rate can decrease from 22% to 12%, and these two techniques can increase the accuracy of histological better subtypings also. So finally, the clinical implications. As you all know, the small renal mass, the typical treatment is either NSS or thermal ablation or active surveillance. Renal mass biopsy can help in deciding the critical decision making in patients with potential surgical risk. Say for example, a patient of 80 years of age with significant medical comorbidities for a tumor of less than 3 centimeter size, when both the surgeon and also the patient in a dilemma whether to go ahead with a partial nephrectomy or to keep that patient under surveillance. Till today, we used to rely only on the basis of the imaging, whether to put this patient on surveillance or to give an active treatment. But now we have a biopsy. You can do a biopsy and find out what grade it fits into. If it is fitting into a favorable malignancy, maybe you can put him on surveillance. If it is a non-favorable malignancy, you can take the risk of going ahead and do a surgery. So finally, the take home, coming back to again the same thing, when there is a renal mass, if your suspicion is lymphoma, renal abscess or metastasis, then there is an indication of renal biopsy. If there is no suspicion of lymphoma, abscess or metastasis, then the question to be asked whether this is a potential candidate for active surveillance. If the answer to that question is yes, then the next question is, are you going to decide your management plan on the basis of the renal mass biopsy risk stratification? Suppose if it is coming out unfavorable malignancy, if you are deciding to do active treatment, then you should do a biopsy. But if you are not going to decide your treatment or to observe on the basis of the biopsy, then there is no indication of doing a biopsy. You can put those patients directly on surveillance without even a biopsy. If this patient is not a candidate for active surveillance, then the next question to be asked, are you planning to do thermal ablation in these patients? If the answer to that question is yes, then you should do biopsy before doing thermal ablation. And finally, if both the patient and the surgeon are willing to observe, if the biopsy tells it is a benign lesion, knowing pretty well the non-diagnostic rate of renal biopsy is up to 20%, are the both surgeon and patients are ready to take that risk if it is coming on the benign on the histopathology of a biopsy. If they are ready to take that risk, then you do a biopsy. If they are not willing to take that risk, if it is if they are coming at benign and still going ahead and doing a surgery, then there is no indication to give biopsy. The final message, renal mass biopsy is a safe and relatively accurate clinical tool. It is helpful in select group of patients for clinical decision making. Molecular imaging, radiogenomics may improve the diagnostic accuracy of the renal mass biopsy. Thank you for all of your attention.
Thank you, Dr. Nayak. So, if somebody has joined later than in between the lecture, so let me re-emphasize again the voting pads, that there are options A to F, and you have to click whichever option you feel appropriate. But if it is not of your specialty, please click F and not C, because if you click C, it will be recorded as one of the findings. And as we said, 75% concordance is what we are aiming to say that's a valid consensus. So let's move on. And for clicking the answers, ensure that you click it once the question is completed, because it will record for 15 seconds. So don't do it early on or don't do it later. So we go to the first question. Can we have it on the screen? Yes. So patients with small renal mass should undergo percutaneous biopsy prior to considering active surveillance. And you can see your responses, are they getting recorded or not? Yeah, next. The second question, patients with small renal masses should undergo percutaneous biopsy prior to considering non-ionizing ablative therapy. Thank you. Then the third question, patients with small renal masses should undergo percutaneous biopsy prior to considering SABR or SBRT. Sorry? So can we have a replacement of pads for someone whose pads are not working? Yeah, we'll wait for a few minutes, couple of minutes till we sort it out, yeah. And thank you for bringing it up because that is more important. You're voting?
Kindly stand up to say whose pads are not working, they will replace the pads just now. Please stand up, claim a new pad.
Yeah, can you rush through? Yeah.
Come on, guys, it's not even lunchtime yet. So run, run, run. It's typically Bengali, you see.
So what do we do?
Those who have joined new, like Professor Karmakar, press the red button, Dilipda, press the red button to put it on, then your option A, B, C, D, E, and then say OK.
Yeah. So can we start now?
Have we all got replacements? Are they working?
No, working only will be evident later.
Yeah, right, okay.
Yeah, so we move on to the next question. Patients with small renal masses should undergo percutaneous biopsy prior to considering partial nephrectomy. That's great. Next, patients with small renal masses should undergo percutaneous biopsy prior to considering radical nephrectomy. Yeah, thank you. That finishes the set of questions for SRMs. Maybe invite Dr. Utsav for the next speaker invitation.
Thank you, sir. Now I would like to invite Dr. Ashwin Malia to talk on the role of active surveillance in SRM.
I'll interrupt you 1 minute. I think one thing has been noticed. Some of the voters are double tapping. If you double tap, it automatically cancels your voting. You have to decide before tapping which one you tap. Suppose you change your mind and tap again, don't do that. You switch on again, switch off, switch on again and do it. Then it within the time frame. So, when you have to decide beforehand whether you're going to vote for Mamta or Modi. It's very debatable, but you know, you have to decide. Thank you.
So what? Yeah, good morning. Can I have my slide, please? Yeah. So my topic for the day would be the role of active surveillance in small renal masses. So the outline of the talk would be I'd take you through what a small renal mass is, and some of it has been covered by the previous speakers. How to select candidates for active surveillance? What is active surveillance in the context of small renal mass? What are the outcomes of the active surveillance based on current evidence, existing guidelines, and a few cases to discuss and some take-home messages. So as we all know that any mass in the kidney that is less than or equal to 4 centimeters found incidentally on imaging, patient is asymptomatic for that renal mass, generally classified into the T1A category. And the radiological characteristics are suggestive of a malignant mass. And this is becoming increasingly common, as we know, because of the increased use of cross-sectional imaging. So these masses are a heterogeneous group. So usually low stage or low grade at detection, and the chance of malignancy and grade worsen with increasing size of the mass. So large studies have shown that 20 to 30% of these tumors are benign and 70% are malignant, but of those 70 to 80% are low grade malignancies. So let's go through the rationale of active surveillance in the context of small renal mass. As we know, most of these are low-grade malignancies, and with increasing age, in 50s, 60s, so a lot of comorbidities associated with the patient. So the comorbidities or the increasing age make competing causes of death more likely. So more often, we see very elderly people dying with the small renal mass rather than of the small renal mass. And there is convincing data by Pierorazio et al. That cancer-specific survival with active surveillance is similar to primary intervention at medium to long term. So we'll go through some of those studies. So let's go through the natural history of SRM. A lot has been studied about it. The average growth kinetics is around 0.28 centimeter per year. That's approximately 3 millimeters per year. And 70% of enhancing masses will show some growth kinetics within the first 2 years. But be aware that lack of growth does not rule out malignancy, and growth kinetics alone may not be sufficient to decide. And the size of the tumor determines the malignant versus benign behavior. And the higher the Fuhrman grade of or a ISUB grade of a small renal mass, the higher the chance of METs. So when we talk about small renal masses, comorbidities are always something that we have to think about. So these graphs show you the death cost due to the RCC versus competing causes. So as the size of the tumor increases, the death due to the renal mass increases, and as the age increases, as you can see, the Charlson's comorbidity index plays more of a role, and competing causes of death. So as the size of the tumor increases and as the age increases, these are the factors that we have to consider. So for a given mass, the cancer-specific mortality would be similar across Charlson's comorbidity groups, but because of the fact that sicker patients, they will have death due to competing causes. And as you may have read before about the Charlson's comorbidity index, so this considers several factors for which score is provided and the total of the score is considered. So how to select candidates for active surveillance? So logically speaking, as we have gone through the discussion so far, so age is a factor, how much life expectancy is remaining is a factor, the comorbidities and the size of the tumor, and biopsy, if it has been done, can help us decide whether to put the patient on active surveillance or whether to intervene. So there are various life expectancy calculators available. So there are some, I took it from one of the studies that I was reading about active surveillance. So estimated life expectancy by comorbidity group. For example, if a person is 70, so this is the US data. So if he has no comorbidities at 70, he has around 16 more years of life left. So with every increasing comorbidity or severity of comorbidity, so that is going to worsen. So these are factors that should be considered. And when we discuss active surveillance with the patient, he or she should be made aware of all therapeutic options, potential risk of cancer progression, the potential loss of opportunity for nephron sparing surgery or minimally invasive surgery, and lack of curative therapy lack of effective curative therapy if METs appear. So a lot of these things are changing because we are getting more information based on renal mass biopsies, and more studies are now showing that the cancer-specific survival is not worsening so much, even if you put the patient on active surveillance versus primary intervention. So this is the study I was talking about, the DIS-RM study, led by Pierorazio et al. This is a multicentric study based in the United States, where they recruited about 497 patients to begin with, and they studied longitudinally how these patients have done when they were put on active surveillance versus primary intervention. And there was a clause of delayed intervention if there is progress on active surveillance. So they tried to figure out a way in which they could decide whether they could put the patient on active surveillance or whether to intervene primarily. So they gave some major criteria and minor criteria based on the age, the ECOG score, Charlson's comorbidity index, tumor diameter, etc., and some minor criteria as well. So when they found that, they proposed that if the score is more than 7, this can be more than or equal to 7, the patient can be a favorable candidate for active surveillance. If the score is less than 3, may be a favorable candidate for surgery. And the intermediate group, that is between 4 and 6, is when other factors will help you determine, for example, a renal mass biopsy. So you went through the slide with the previous speaker as well. I just want to take your attention to, is the patient an AS candidate? And do a biopsy only if you think there is a clinical benefit to histological risk assessment. And if the patient is willing for biopsy, go ahead for it. But the fallacy of biopsy. It's useless if it is non-diagnostic. So studies have shown that after you do a second biopsy, even then you can miss it 20% of the times. So the negative predictive value for if the result is benign is 67%, meaning 1 out of 3 benign, so-called benign diagnosis would still be harboring a malignancy. And even if it's non-diagnostic, you can't breathe easy because still there is a chance that there is 80% chance of malignancy in that patient. So what is the role today? Contemporary series have shown significantly improved rates of diagnostic biopsies. What used to be 70 to 80% is now close to 90 to 95% of diagnostic biopsies, and good concordance of about 92 to 95% with very few major complications. Today we cannot quote that it's because the risk of needle tract seeding, we are going to avoid a biopsy, because the technique which is used is a coaxial sheet technique, where the risk of tumor seeding is less than 0.01%. And biopsy continues to be a tool in selecting appropriate candidates for focal ablation or active surveillance. So the risk factors for a non-diagnostic biopsy, again I'll reiterate, is a neoplasm under 2 centimeters, presence of a cystic component, increased skin to tumor distance. So evaluating for these tumor characteristics can help identify those who would not benefit from a biopsy. So the DISRM study, I just wanted to take your attention to the protocol that they followed, the observation protocol when on active surveillance. So CT scans every 4 to 6 months for the first 2 years, quality of life questionnaires at 6 months, 1 year and 2 years, and for the next 3 years, CT scan every 6 to 12 months. So obviously there is a lot of imaging being done. So if you are thinking about doing this in younger patients, it is going to be a lot of imaging. So that's where the problem with active surveillance in younger patients. So what are the triggers to stop active surveillance? When the tumor size goes to more than 4 centimeters, the growth kinetics show that there is more than 0.5 centimeter growth every year. The tumor volume doubling time is less than 1 year based on the volumetric analysis of the tumor. Patient has symptomatic or clinical progression. For example, a small renal mass which was absolutely symptomatic, then the patient develops hematuria and you've ruled out other causes. Okay, there is some clinical progression. And the patient choice, obviously. Patient is anxious about his malignancy and he wants to go ahead, because once that, even if it's a 70-year-old otherwise healthy man and you've done a renal mass biopsy, for example, now you've told him that he has a, low-grade RCC, but still that keeps playing on his mind. So he may choose to cross over to intervention. So let's go through what the long-term outcomes of the DISRM registry is. So this study was published in 2015, where they did the 5-year analysis of this registry. What they found was the overall survival for both the primary intervention and the active surveillance was 98% and 96% at 2 years. But obviously active surveillance patients had higher comorbidities. So the overall survival decreased when they reached the 5-year point. It was 92% for primary intervention and 75% for the active surveillance group. But when the cancer-specific survival was, calculated, it was 99 and 100% for the primary intervention and active surveillance. And they concluded that in a well-selected cohort with up to 5 years of prospective follow-up, active surveillance was not inferior to primary intervention. So why the hype? Considerations for old versus young. So this is where the role of age is. So active surveillance has been established. I think all of us are practicing it as a safe treatment strategy for the elderly and infirm, where competing risks of mortality are there. But in the young, the risks of intervention itself is generally low, and the perceived oncologic stakes are significant. And there is a burden for lifelong close monitoring, which is judged to be unreasonable. But also the point to be noted, there may be a 35-year-old male who leads a very busy professional life. And the disruption by the SRM treatment itself can be a significant life stressor and challenge. So what did the DISRM registry find? For those, so they published this in 2021. So they published this data of patients who were less than 60 years. And there were 224 patients, and they did a 7-year follow-up. they found that among the patients in whom the initial tumor size was less than or equal to 2 centimeter, there was 15% crossover rate from active surveillance to intervention. Whereas when it was between 2 to 4 centimeter, it was around 1/3 of the patients. And overall survival was similar at 7 years for active surveillance as well as primary intervention, and there was no significant differences with respect to minimally invasive or nephron sparing interventions. Recurrence-free survival at 96 and 100% for primary and delayed intervention. So they concluded that active surveillance is a safe initial strategy in younger patients and can avoid unnecessary intervention in a subset for whom it's durable. Obviously, this is as more and more data is emerging, a lot of the controversy may be put to rest, but we'll watch out for this space. So what do the guidelines, contemporaneous guidelines tell us? So for T1A tumors, the NCCN suggests that you can go ahead with active surveillance. And active surveillance, what they say is for solid renal masses less than 3 centimeters, for cystic renal tumors less than or equal to 4 centimeters. Also keep doing some studies to figure out whether the patient is developing metastasis. That is also important. So EAU, the summary of evidence. So the growth of SRMs in AS cohorts is low in most cases and progression to metastatic disease is rare, 1 to 2%. So let's go through some real world scenarios from my own personal practice, and these are some of the cases. 77-year-old male, diabetic, who had a stroke 2 years back and incidentally detected during that episode to have a 2.5 centimeter tumor on imaging. So he was kept on active surveillance, serial imaging for 2 years now. The current size is around 3 centimeters. He continues to be on AS with kinetics of around 0.25 centimeter per year. A 68-year-old male with coronary artery disease and PTCA has been done and incidentally detected 2.5 centimeter tumor on imaging. Biopsy, patient had presented to the nephrologist who went ahead with the renal mass biopsy by IR. And the biopsy report was oncocytic tumor, chromophobe cannot be ruled out. We went ahead and did a robotic assisted partial nephrectomy and we found a chromophobe RCC. This was a 42-year-old male, healthy male, incidentally detected 1.5 centimeter tumor, and due to personal reasons he delayed his treatment, and within a year the size increased to 2 centimeter, and we did a surgery and partial nephrectomy, we found clear cell grade 2. So the take home message is, so small renal masses are a heterogeneous group, minority will show aggressive behavior. There is convincing data currently regarding the safety of active surveillance in the elderly and comorbid population. And in the younger population without comorbidities, the feasibility as a safe initial strategy has been demonstrated. There is the increasing experience with renal mass biopsy makes it a safe option in equivocal cases. And with the introduction of biomarkers and better genomic studies, probably we will be able to stratify patients on active surveillance better. Thank you.
Thank you. So if you get the next set of questions up on the role of active surveillance. We can get that on the main screen as well. We're not up there yet.
Can we get the questions?
Okay. So we've got 8 questions on active surveillance. So starting off with a nice simple one. Patients with a small renal mass can be offered active surveillance as a management option. And if you move on to the next question. So question 2, patients with a Furman grade 3 small renal mass on biopsy can be offered active surveillance as a management option. Ta-da! Next question, please. So, statement 3. Patients with a complex renal cyst, Bosniak 3, can be offered active surveillance as a management option. Next question, please. So patients with a small renal mass and a genetic predisposition to renal cell carcinoma, for example, VHL, oxygenate dehydrogenase deficiency, can be offered active surveillance as a management option. And next question. So the optimal surveillance imaging modality for patients with a small renal mass is a kidney ultrasound. Next question. So number 6, the optimal surveillance imaging modality for patients with a small renal mass is a dedicated kidney CT. Next statement. The optimal surveillance imaging modality for patients with a small renal mass is a dedicated kidney MRI scan. And the final statement, patients undergoing active surveillance for a small renal mass should have the frequency of imaging determined by the grade of the tumour on biopsy.
Okay. You should not. You should not.
Okay, thank you.
So we move ahead for our final talk in this session by Dr. Anupam Lal on the role of non-ionizing ablative therapy.
Good morning, everyone. I thank the organizer for having me here. I am Dr. Anupam Lal, and I'll be talking on small renal masses, the role of non-ionizing ablative therapy. Ablative therapies in kidneys have gained popularity because they are minimally invasive and patient morbidity is less. But is there sufficient evidence that it is competing with the surgery? Previously, only those patients who were not fit for surgery were subjected to ablative therapy because surgery used to be gold standard. Now the literature is flooded with so many reports And the last 5 years, you see more than 200 reports of different series, small and large, proving the efficacy and safety of ablative therapies in kidneys, especially with small renal masses. And these two meta-analyses are very supportive. One published in Clinical Journal of American Society of Nephrology and in Journal of Urology. And this meta-analysis involved 58 different series. So it's a large, robust data to suggest that disease-free survival was similar and local recurrence-free survival was better following partial nephrectomy, not significantly much higher than compared to ablation. However, when retreatment and secondary efficacy, ablative retreatment and secondary efficacy, the outcome following the partial nephrectomy and ablation was very comparable. This is another very strong supportive evidence which was published in British Journal of Urology. This is comparison of 7,704 nephron sparing surgeries and 1,114 renal ablations, and they have shown that the 5-year disease-free survival rates were comparable. American Urology Association has included as a treatment option T1A tumor for ablation therapy. And now we know with this robust data that the safety and efficacy of ablation for the treatment of small T1 RCC, whether it's T1A or B, both included, have been more than success rate is more than 90%, and secondary clinical success rate more than 100%, up to 100%. So before ablation, what are the things we should look for and consider that this patient is fit for ablation? And we have a systemic review method, and mostly we do cross-sectional imaging, triphasic CT and other imaging modalities as and when required. We look for certain important parameters, and that can be remembered with this acronym ABLATE. So what are these parameters? One most important thing is the axial tumor diameter. So ablation is most suited for less than 3 centimeter size tumor, and this is true with RFA but not with other modalities. Nowadays we are doing ablation for larger tumors also, like microwave and cryo ablation is done for okay with a larger tumor. If the tumor is more than 5 centimeter in diameter, then we prefer to do a embolization prior to ablation to prevent, to minimize the bleeding risks. Another important parameter is proximity to bowel. If the tumor is close to bowel and distance is less than 1 centimeter, we do a separation technique or a hydrodissection or increasing the distance by maneuvering the patient position in the table. Location within the kidney is also important. Anteriorly placed tumors, bowel is usually closed, so we do a separation technique. Then we might do a transhepatic approach or put patient on alpha receptor blockade if it is close to adrenal, and if it is close to psoas, then we have to do a suppression technique to protect the nerves over there. Then if the tumor is very close to ureter, we might consider a pyeloperfusion to cool the ureter and decrease the thermal injury. Renal sinus fat, if the tumor is close to the renal sinus fat, we may consider cryoablation, because cryoablation is relatively less damaging to the, for the regions I'll tell you in the subsequent talk. Tumor is endoexophytic, that is important. Exophytic tumors are very easy to ablate. Endophytic tumors, a clear delineation of the tumor is required, and for that we place our probe or antenna in with ultrasound. So we might do a contrast ultrasound, like in this image. You see contrast ultrasound delineates the tumor, so we know the exact extent of the tumor. However, in this case, you can see the tumor here. So now, what are the modalities of ablation commonly used in renal ablation? Can be broadly divided into thermal and non-thermal. Thermal, we have radio frequency ablation, microwave, laser, and high intensity focused ultrasound. Non-thermal, we have IRE, which is very good modality, but is slightly expensive and it requires a lot of expertise. It is irreversible electroporation, and it involves very high voltage current for a millisecond that damages the cell membrane. Cryoablation I will discuss, and in chemical it's not very popular, but sometimes we use ethanol for ablation of small tumors. So RFA is very popular, it's most commonly used, and in RFA the ablation zone is not very uniform. In periphery, because of heat sink effect, the tumor may not be ablated properly, so that we take a safety margin of say 5 to 10 mm around the ablated margin, so that the entire tumor is covered. Microwave has gained popularity because it is fast. Moreover, it is less affected by the heat sink effect, and it is kind of ablation margin is relatively uniform than what is with RFA. Cryoablation has the advantage that we can clearly see the ablation during the procedure, by you can visualize the ice ball that forms around the probe, and you can exactly see whether the tumor is included within that ice ball or not. However, cryoablation require more expertise, and it entails more complications like cold shock and hemorrhage. Ethanol I have discussed, it requires not very specialized instruments, very easy to use. And irreversible electroporation is important because it is not affected by the heat sink effect, one. Second, it protects it relatively not damages the collagen and the vascular structures. So tumors which are very close to these structures can be used with irreversible electroporation. Now see, this is the image to show that how the ablation margin looks like with RFA, microwave and cryoablation. See, the RFA margin is irregular. In the periphery, because of the heat sink effect, the ablation is not uniform. So that is why we use a safety margin of 1 centimeter. Microwave is relatively uniform, and cryoablation is very clearly delineated ablation. If you compare the cost and experience and ease of use, RFA and microwave are the most popular. Most experiences are with RFA and microwave. They are easy to use. And outcome of microwave and cryoablation are much better. IRE is still becoming popular, but it is a costly set of affair and require a lot of expertise, so not available in many centers. Now this is a comparison of RFA and cryoablation, and you see number of tumors treated. Complication with cryoablation was slightly more than that with the RFA, but local tumor control is comparable here. Now, how do we follow up after ablation? There's early post-procedure imaging is done with CT, cross-sectional imaging, CT and MRI, and follow-up imaging is usually done at 3, 6 and 12 months post-ablation. And during the entire process of ablation and post-ablation, complication imaging is done with complication monitoring is done with imaging and clinical assessment. A few examples: exophytic, well-defined renal tumors. We don't do a lot of biopsies. If triphasic CT is very sensitive of a tumor, we don't do biopsy. During the just before ablation we do the biopsy. Not that we do a biopsy and then decide for ablation. Just before ablation we do the biopsy to confirm. So this is exophytic tumor and very easy to do ablation. You can see this coronal image tumor here and this ultrasound guided placement of probe, and this is a multi-prong RFA and the result. This tumor here is at lower pole of the right kidney, so it is slightly anteriorly close to the colon. So we have to do a hydrodissection here, and this is how we displace the colon by putting saline injection. Here you can see in the coronal image, putting saline between the colon and the tumor and doing ablation here. Then centrally placed lesion. One problem with RFA and microwave is that while you are doing ablation, microbubble forms. This is the RFA probe, and during ablation microbubbles form and the visibility is obscured. So that problem is there, and this problem is not there with cryoablation. You see this relatively larger tumor in the left kidney, and this was decided that we will do a cryoablation because of the large size of the tumor, and we put 2 cryoprobes in this tumor with ultrasound guidance. You can see these 2 cryoprobes here, and you can now see that clearly the ice ball which forms around the probe, which can be clearly delineated on CT. So you know exactly the tumor is within the ablation zone or not. So this is the result. This is another case, metastatic gallbladder malignancy to kidney, relatively large tumor, cryosurgery, cryoprobe, ice ball here, and the ablation. This is an interesting case. This was a post-RFA clear cell RCC which was ablated, and you can see follow-up imaging. There is small enhancing nodule in the ablated zone, and you can see a small vessel traversing to this lesion. So this is a clear-cut recurrence. So what we decided, this is a very small recurrence. We will do a percutaneous ethanol injection, and on contrast ultrasound guidance, we injected ethanol, absolute ethanol, into this tumor, and entire vascularity is gone now. Contrast MR subtraction scan show no enhancement here. This is tumor is now the necrotic tissue is surrounded with fat, and the PET scan also confirms that there is no uptake in this area. So this is briefly about ablative techniques, and I'll conclude by saying that renal tumor ablation stands as a promising and minimally invasive solution, demonstrating efficacy in tumor control while preserving renal function, heralding a paradigm shift in the comprehensive management of renal tumors. Thank you. I go down.
Thank you, sir. Sir, you can join on the dais. Dr. Lal, sir, you can join on the dais. So we move on to the next set of questions, and there are 12 of them. The first question: non-ionizing ablative therapy for small renal masses should be offered in high volume centers. That is, a minimal level of expertise and experience needs to be determined. Next, patients with surgically resectable small renal masses can be offered non-ionizing ablative therapy as an alternative management option. Next, patients with surgically resectable small renal masses but who decline surgery can be offered non-ionizing ablative therapy as an alternative management option. Next, patients with surgically resectable small renal masses but who are at high risk due to medical comorbidities can be offered non-ionizing ablative therapy as an alternative management option. Next, patients with surgically resectable small renal masses but who are inoperable because of medical comorbidities can be offered non-ionizing ablative therapy as an alternative management option. Next, patients with surgically resectable small renal masses but who are at high risk for needing dialysis post-resection can be offered non-ionizing ablative therapy as an alternative management option. Now, cryotherapy is preserved non-ionizing ablative therapy technique when treating small renal masses. Next, radiofrequency ablation is a preferred non-ionizing ablative therapy technique when treating small renal masses. Patients undergoing non-ionizing ablative therapy for small renal masses should have biopsy performed at the time of procedure if not performed prior. Next, patients with ipsilateral recurrence of small renal masses following previous non-ionizing ablative therapy can be offered a second non-ionizing ablative therapy. Next, patients is suitable for cryotherapy ablation for small renal masses should be offered this percutaneously. Next. Patients suitable for cryotherapy ablation of small renal masses should be offered this laparoscopically. Yeah, thank you. So that's finished the set of questions for this session. So we would start the next session, which is again on renal masses. And I would invite the coordinator, Dr. Anush Sharma, to introduce, and we'll also change our chairpersons. Thank you very much, and the panelist speakers. Thank you. Meanwhile, I have an announcement to make. There are kiosks in the trading area for viewing posters and the videos. Those e-posters and e-videos have been already judged by our experts. I would request anyone and everyone who gets time to visit that kiosk and use those posters and videos to see them.
Dr.
Yeah.
Ravi,
Yes.
there is no option of asking any question to the presenters in the whole conference, isn't it?
Yes, I think asking questions are going to get biased. They
No,
make
no.
you biased with
So
respect
in
to
the,
answers.
in the presentation, if you have a query, so there is no option of asking such query. Or we can just ask it over a cup of coffee.
So, yeah, you can ask it now. Maybe now what we can do is in the next session, at the end of the session, when once all questions are answered, then you can ask questions to the speakers, so that, yeah, fair enough. We did not want in between because that would create some biased answers. Yeah, we can do it now. Yes, why not? Yeah, and we can have the speakers coming back on the dais, please. Dr. Rajesh Nair, Dr. Gopal Sharma, Dr. Brisbanu Naik, Dr. Ashwin Malia, and Dr. Anupam Lal sir. I'm so sorry for not allowing you this to answer that query.
And this will break any sleeping partners like Professor Gupta. I mean, we need some pill to wake him up. So I think this is going to be the way. I mean, I think, thank you for suggesting, whoever suggested it. Let's have these questions. Let's all wake up and then we'll go to the next session. Yep.
We talked
Open
all
to
about-
questions. Who's asking? Yeah, Makarand.
We talked all about these alternative therapies, radiation, the biopsy, cryo, RFA.
Aste.
Basically, we all know it distorts the anatomy after the biopsy as well as during the procedure. Now, when we follow these patients, how do we know there is a local recurrence? Because A, the anatomy is distorted. Even for the radiologist to talk about whether there is sort of, enhancement, no enhancement or architecture change is very difficult. And when do we do a biopsy when you suspect sort of, there is a recurrence?
I can try and answer that. I think the first thing to say, it's difficult. You're absolutely correct, and this is why experience does count in, even just as experience counts in partial nephrectomy, experience counts in the ablative therapies. In the UK, we have interventional radiologists that perform the ablative therapies, and they often follow up these patients much more stringently with CT scans on a 3-monthly basis for the first 1 to 2 years. The problem with rebiopsying is that you often hit necrotic tissue or calcified tissue, which doesn't yield a good diagnostic yield. Local recurrence occurs at the periphery of these tumors, and so biopsy needs to be targeted at the periphery. It's often the CT scans that show enhancement, and time will often tell you if there's progression of disease or recurrent disease. Usually if you're doing these ablative therapies, you're doing them for lower grade tumors on biopsy normally. And often there is time to see visual change over a period of time before you can commit yourself to treatment. So just because there's subtle change at 3 months, you can afford, 9 times out of 10 to wait another, 6 to 12 months to really see the convincing evidence of change. So often it's the imaging that gives you the answer.
I just wanted to make a comment about especially one scenario in active surveillance was not discussed, which we often commonly face, is the elderly population with renal failure and mass which is not 2 centimeter, which with 3 and 4 centimeter. Here question comes, let him carry with this the quality of life, get it out, and then give him a dialysis, which is again a different changing the quality of life and all that. So there one has to weigh advantage and disadvantage. So let him, even if it is going to 5 centimeter, very slowly growing in elderly population with renal failure, we let him go. Rather, his quality of life is better rather than going to the dialysis.
So that probably, sir, would be covered in the talk which have in the next session on radical nephrectomy in SRMs. So probably that topic would be covered there.
It was a wonderful session in the whole morning, and Anupam Lal, talking about the minimal invasive treatment or local treatment. I think there is definitely a place, and we have just started in India, and though earlier we would wanted to try, but there was no company support, because cryo, you cannot do it. You can't buy the machine and do it. You need to have a company support, and we couldn't do it. But I feel for a urologist, I think cryo is very good for the small renal mass, but it should be done laparoscopically. Because what is important is placing the needle where the tumor is. When you do the laparoscopy, you can put ultrasound inside and then localize the thing, you can mark it out, and then put a needle. And cryo is, very well done, and if you do laparoscopically, you will have more patient being treated, because now we find nearly 45% of new diagnosed cases as a small renal mass, T1, T2, and at the moment they're all going for a partial nephrectomy, but they would be the candidate, and beside, this minimal invasive will remain with urologists.
Thank you. Dr. Lal, your comments.
I agree with sir that open or laparoscopic placement of cryoprobe is gives better results. Definitely it does. And tumor up to size 5 centimeter can be easily ablated, because in cryoprobes, what is the advantage? You can put multiple probes. So you can ablate larger tumors. About biopsy, we are slightly skeptical to do biopsies in all lesions what we see. A good triphagic CT is good enough to say that this is RCC or not. And smaller the lesion in kidney, more chances of it being benign than a larger lesion, more chances of it being RCC. So smaller lesion we are slightly skeptical and we may do biopsy. Larger lesion we usually don't do.
Sir, I have a
Dr.
question.
Mayank, yeah.
So if we are doing cryo laparoscopically, what is the point of doing a cryo? Why not to remove the tumor, have the whole thing for the histopathology, rather than take a biopsy, do it laparoscopically, then put a cryo probe, see what the results will be in future, maybe a recurrence and all that. That sounds little, not so scientifically sound, one. And number two, are there any practical risk of repeated radiations given by these triphasic CT scans when the patient is on active surveillance? Can we switch it? Can we just avoid these CT scans, and maybe a good quality ultrasound can follow it up? If it's increasing in size, then only do CT or MRI selectively.
Yeah. Yeah. Mike, please.
Yeah, that's a very good point, sir. So if you see the NCCN guidelines as well, so they are not recommending that you have to go for a contrast enhanced CT every 6 months. So after the first year, you can switch over to an ultrasound or an MRI intermittently. So you are going to require annual scans. So that is why the whole point about avoiding active surveillance in younger patients rose from this point that you're going to have repeated contrast enhanced imaging. So more and more, as we have more and more data, probably. So, but I don't think anybody has studied, how much of a practical risk in the long term due to radiation-induced damage.
I will like to make a comment on this. In this particular scenario, a DCT scan, dual energy CT scan with triple bolus in a contrast is very good because it reduces the radiation to the tune of only IVP, around 15 to 25 SEV, where the conventional CT is giving you a radiation of 67 to 70 SEV. So they have especially recommended it that this kind of modification in CT acquisition images should be done only when you are doing the follow-up or low-risk patient, not for the diagnosis or high-risk patient. So in this particular scenario, DCT scan with triple bolus contrast is very good because in that you don't require a plain unenhanced CT. You just do it, get it done by the post-processing imaging. So that reduces the CT scanned radiation by 1/3.
Thank you. Thank you.
Thank you very much.
Yeah, I think I was about to make that point. If you're doing a laparoscopy, why not to do a partial laparoscopically? But I think it's possible only for an exophytic lesion. If you're an endophytic, then jolly well you can put a cryo. As far as follow-up is concerned, we do rely mainly on MRI, especially we have a long series of von Hippel-Lindau disease, where you have more of a solid as well as cystic lesions. So I think the MRI plays much more less amount of radiation and it scores much better than sort of using a contrast and having further nephropathy. Having said that, we are using these patients for CKD, medical renal disease, unfit patients. So anyway, we don't use that sort of CT so often. We rely mainly on MRI.
I think that's a very good point, actually. When you look at guidelines, guidelines are generalizable for people, but often the problem with renal tumors is it's there's a personalized tumor and a personalized individual that you have to deal with. So if a tumor is obviously clearly seen on ultrasound scan, then ultrasound might be the right modality to follow it up. If it's not visible, if its architecture is not clearly seen on a CT scan, it might be an MRI. If the patient is young, 17-year-old with VHL, then clearly they don't want a lifetime exposure of CT scan, so MR might be useful, or ultrasound and alternating. So you do have to understand the context in which surveillance is being taken.
My point is on the follow-up. We've had some talk that you might not be able to tell very clearly if you're seeing a recurrence after local ablation or it is simply an artifact. Now, one of the points if there's a recurrence is to retreat, and you can retreat it focally. I mean, if any of you who have experience in this, how confident are you to go in again in an area which is not very sure? Would you ablate it or would you do a partial and get rid of the problem?
Excuse me, sir. This is about active surveillance. Say, active surveillance, yes, it is suited for Western countries, but in India, where we have n number of government and private medical colleges, say, what's the role of active surveillance? I don't think we have a specific set of protocol for follow-up of active surveillance patient, number one. Number two, suppose in case, if they landed with a metastatic disease, who will hold the responsibility from a medico-legal point of view?
Yeah, Ashwin, you want to take it? Or maybe Dr. Nayak?
The risks, when you are discussing the option of active surveillance, everything has to be, explained to the patient. But the practicality of that is not the point you made. The very fact that you have so many medical colleges and so many institutions means that institutional care is going to be available to the patient. Secondly, the chance of metastasis, especially in patients who have less than 2 centimeter tumor, is close to, it's less than maybe 0.5% over the next 5 to 10 years. And as the size increases, obviously you are going to take action. So for that minuscule number of patients, you need not deprive the whole population from, for AS. And the point of AS is to select better patients. Select patients when they are progressing. So when you have so many institutions, I think AS protocol should be put in place. So that is, I think that point is not...
Yes, at present, I don't think we have in medical college at least.
The consensus guideline is essentially aimed to develop some consensus, so that's the beginning. Yeah, Dr. Rishi.
Fine.
So when we are talking about the ablative therapies being less invasive, what we think is we generally avoid the anesthesia being the more important factor than the surgery itself with regards to the risk to the patient. I'm speaking from my personal experience. When I had sent a few patients for RFA, ultimately those patients actually ended up requiring analgesia because the ablative therapy itself was so painful during the procedure that the patient required anesthesia at that time. So what I'm saying is we may not end up avoiding the risk of anesthesia, and the risk of complications would still be there, hematuria, etc. Would be there, and to top it, there would be risk of leaving a lesion there which has not been ablated. So therefore, we really have to be careful when we give this choice to the patient. To my mind, whosoever is fit for surgery, generally surgical treatment would be the best option.
I think that's a very good point. I don't disagree with that point. I was just going to come back to the point about retreatment. I think retreatment in an area of local recurrence following RFA or cryotherapy is difficult. You can retreat again with the same modality, and that's usually preferable, but it just depends in the context. If you have a single kidney, then retreatment with minimally invasive may be beneficial rather than risking a partial nephrectomy and losing the kidney and putting a patient on dialysis. I've only done a couple of partial nephrectomies in previously cryoablated tumors, and they are very difficult because there's no fat plane. You end up cutting into the kidney inadvertently. It's not an easy operation, and the chance of renal loss is definitely much higher. And then you have to understand for what gain are you doing? Are you going to be confident in getting a clear surgical margin in these patients and avoid a leak in tissue that's unhealthy? So normally, if you have 2 renal units and you have a recurrence post-partial and the GFR is good, I would just move on and do a radical nephrectomy in those patients.
Fair enough. Thank you. So, yeah, Dr. Lal.
I don't think require a general anesthesia. Only IRE patients require a general anesthesia. Otherwise, conscious sedation and good analgesia is good. Second thing about local recurrence. Everything is not available in all the centers. So whatever is available, use best out of that. And as somebody has pointed out that do a CT, just a dual energy CT, limited sections of the kidney. So that gives a virtual non-contrast image, so we immediately know whether it is enhancing or not. Dose is very low. We have a very low threshold of doing a contrast enhanced ultrasound. And it gives you, it's exquisitely sensitive for enhancement. So even if there is a lot of scar, everything is there, you'll see enhancement and you know where you have to biopsy.
Fair enough. Thank you. Thank you. So with that, I thank again, and thank you, Dr. Mayank, for bringing up that discussion. So thank you, chairpersons and